Welcome, everyone. Thank you so much for joining us. I'm Cheney. I'm Senior Editor for Special Coverage at Devex, and I'm really thrilled to be moderating this conversation on how to make safe surgery a right, not a privilege. So as many of you know, and part of what brings you here, I'm sure, over 5 billion people, and predominantly in low and middle income countries, lack access to safe, timely, and affordable surgical care. We know the barriers, including distance, fragile infrastructure, and a severe shortage of trained surgical professionals. But we also know there are solutions. And in today's conversation, we're joined by several experts who can help us understand what's working, as well as the challenges that lie ahead. So I'm thrilled to be joined by several experts here. I'll go ahead and introduce them briefly. I'll start with a conversation with Dr. Elizabeth Coté, Head of Global Programs at Operation Smile, who is leading the organization's work to build sustainable, locally led surgical systems and train the next generation of providers. Then we'll hear from Professor Faustin Dr. Faustin Ntirenganya, Head of Surgery at the University of Rwanda and President of the Rwanda Surgical Society, as well as Stella Itungu, CEO of the College of Surgeons of East, Central, and Southern Africa. Before we dive into the conversation, we're going to start with a brief video to help frame our conversation today.
We all have scars. And our first instinct is to hide them. But scars deserve to be seen. Because they're not marks of something that went wrong, but something that went right. The first line of a new chapter. Badges of hope that should be worn proudly. Scars are signs of something we all need. Access to safe surgery. Something 2/3 of the world doesn't have. At Operation Smile, we believe safe surgery is a basic human right. Operation 100 will bring lasting surgical care to 100 communities around the world who need it most. And 100 is just the start. We build hope. Donate today.
I thought that video was a really powerful way to capture why we're all here today. This idea that scars are signs of something we all need, access to safe surgery, and that is something 2/3 of the world doesn't have. So we'll be talking about how to close that gap. And there's an important why now for this conversation. It's been 1 year since leaders from the global surgery community came together at the Pan-African Surgical Conference with a shared vision, which is to build surgical systems that are locally led, sustainable, and grounded in evidence. So this is really an accountability moment, a time to take stock on what progress has been made and where the gaps remain. And with that, I'd love to go ahead and welcome Dr. Elizabeth Coté. Dr. Coté, thanks so much for joining us.
Thank you for having me, Catherine.
Absolutely. So, as I just mentioned, the Pan-African Surgical Conference was a year ago, and that was actually where Operation 100, which our audience just heard a little bit about, launched. Can you tell us a little bit more about what inspired this strategy and how it reflects an evolution in Operation Smile's approach?
You bet. So it was wonderful to start with the video because it just emphasizes the universality of not just pain and suffering and the need for surgical care, but really healing and our desire to help each other with that healing. There was a historic approach for 40 years among Operation Smile and many other direct delivery organizations of healthcare, which was one of bringing healthcare to people where they needed it from higher resourced income places. We still deliver more direct surgical cleft surgeries than we ever have before in our history. But now we're using that, and more importantly, the relationships that have been built in 38 countries to respond to the needs on the ground, not just to deliver the care, but to respond to the needs that are beneath the gaps of care. The Pan Africa Surgical Conference was literally a ground swelling of that attention to the needs that volunteers from high income countries were hearing from the ground, from people like Stella, the CEO of COSECSA, and professors and medical leaders like Dr. Faustin saying, we have a community here. We want to deliver excellent, safe care to our neighbors, and we need to be invested in order to do that. The Pan Africa community of surgeons wanted to congregate in order to do a few very specific and understandable things to strengthen their own networks, to strengthen their own ability to do research, to strengthen the systems in which they could deliver that care, and to incorporate it with their ministries of health and NGOs. And so that brought together 500 people in Kigali. It was an amazing success. The energy was palpable. And then the question was, now what? When there's a swell of that energy, of that possibility, and you can see that palpable, feel that palpable potential, what happens after that? How do we make a plan to lead to impact? Operation 100 is the demonstration of a novel plan to link direct surgical delivery with educational opportunities and pathways that upskill entire operative teams, the surgeon, the anesthesiologist, the pre-peri and post-operative nurse, the biomed tech, and other allied professionals in a critical access hospital, a district hospital, so that then care can be delivered where people need it, when people need it, by their own neighbors and the professionals in their own neighborhoods. So that brings us to this present moment and the strategy behind Operation 100, which is already spreading beyond 100 places.
And it's so interesting to hear you mention that you're doing more direct delivery, direct service than ever, but you've expanded your approach. And additionally, I just want to emphasize something you just said, upskilling entire operative teams. The benefits extend beyond cleft palate surgeries specifically. So can you just talk a little bit more about that?
Absolutely. We talk about the surgical workforce gap that's going to lack 2.2 million surgeons. However, that also translates to a gap of 11 million healthcare workers. Half of this gap is going to be in Africa. And what we want to do is make a sustainable team approach. So we are training surgeons. We're using the cleft surgery, which is an amazing, specific, and circumscribed tool. Cleft surgery is as effective in averting disability adjusted life years per US dollar as vaccines. It's incredible. But through providing that surgery with mentors, regional mentors, international mentors, local mentors, for not just the surgeon, but for the anesthesiologist who's now becoming a pediatric skilled anesthesiologist, and the pre-peri and post-op nurse who's now becoming skilled at continuous care improvement, surgical wound infection, and the biomed tech who will operate all and help operate and make safe all of the systems that are needed for delivering essential surgical services. We're now making safer surgery available to 500 million people in the communities alone around these 100 plus hospitals that we are equipping. just to make that a little more succinct, the focus is on a place, an entire team in that place, and then making sure there's competency-based training in that place. So these investments leverage each other and lead to advancements in the Lancet goals, more surgeries that are delivered, more people able to deliver them, from surgeons to biomeds to nurses to nutritionists, and also more care that's accessible within 2 hours of an individual's home.
And can you talk about what success looks like long term here? You've talked about a pretty daunting gap of this shortage of 2.2 million surgeons, and I think you said 11 million in terms of the workforce around that. But you're making progress, you're making strides. What does success look like, and how are you measuring that success?
Success looks incredible. It looks a little bit like the video you saw when we began. It looks like real people. For example, working with the government in Kenya, we identified a district hospital that was on the coastal region and needed to be invested in. And so now I can tell you the name of Dr. Zulal, the name of the pediatrician, Dr. Hiu, the name of the PACU nurse, the pre and post-op nurse, the OR nurse, in whom we're investing education, opportunities to go to conferences, to engage and make sure they're having evaluations and mentorship, and engage in continuing medical education, as well as having flowing oxygen, new OR suites, and the ability to not just do cleft care, but other surgical services. So it looks like community is what it looks like. And it feels amazing because now you have providers, hungry providers that have the resources they've been yearning for, and they know they're not alone. So that's what it feels like. Success feels like frontline providers not being alone. And this intervention goes beyond the hospital administrators, even towards the governments in Kenya with whom we're identifying, and all the other countries with which we're working, identifying where are these critical places of access in which we can co-invest in the place, the space, the stuff, the people, and make sure that there's more delivery of care available.
I love this emphasis on people and
Yes.
your point that that is what success looks like. And we saw that in the We Build Hope video. So I wonder if you can talk about kind of how that video represents part of your strategy, in the sense that you're centering the stories of individual patients, as you have done in this conversation, individual patients and individual providers. How do those individual stories help move policy leaders and people who need to make different decisions to move this agenda forward? How does it help them see the societal value of a strengthened surgical system?
I think, as with all movements towards justice, what knits it together is this feeling of common humanity. There's probably not a person on this call, listening, speaking, who hasn't needed a surgery or had a loved one that needed a surgery. And so when it becomes personal, and it's not only about cleft, which is the most common congenital need for surgery, but it's any type of surgery, especially the most essential ones, it becomes, and it feels not just universal, that it feels personal. And in that moment when universal becomes personal, that's a magical moment where all of a sudden people are fired up and become part of the action, no matter what your role is. And I think it was interesting at the end there was a call at the end of that video that said, your contribution matters. Your contribution matters no matter what boat you're in, no matter what kind of NGO you work for, whether you're a frontline worker, a frontline leader like Dr. Faustin, whether you're helping people across the continent access healthcare education like Stella and Itungu. We all have a little boat on this river of justice, and it's personal. We're all connected to each other with a unique contribution to make, so that surgery is accessible to everyone who needs it, so that everybody who does need healing and could have a scar, which is a badge of hope, is able to receive one within their home communities.
Thank you, Dr. Coté. And stick with us, but I do want to bring in two additional perspectives. You've mentioned them a couple times, and I'm so excited to have them here. Two leaders who are really helping to turn this vision into a reality. So we're joined by Stella Itungu, who leads COSECSA, the organization you heard about earlier, which is training and accrediting the next generation of surgeons across 24 countries and helping to strengthen the regional workforce pipeline. and Dr. Faustin Ntirenganya, who has been really instrumental in advancing surgical education, research, and national policy, and helped co-chair the Pan-African Surgical Conference that set this agenda in motion. So Stella and Dr. Faustin, thank you for joining us. And we look forward to hearing more about, again, how you're working to make this vision a reality. Let's start with you, Dr. Faustin. So as a co-chair of the Pan-African Surgical Conference, you help to convene leaders around this shared vision we've been talking about for advancing surgical education, leadership, research, and policy. So now we're a year from that moment. As I mentioned earlier, it's sort of an accountability moment. And I wonder if you can tell us to what extent you've seen that vision turn into real world change, and what have some of the challenges been in terms of seeing the kind of progress you want to see?
Thank you very much. Good evening, good morning, everyone. Thank you for organizing this important gathering. And actually, this is a very crucial question, and thank you for putting it right way. Allow me to thank Elizabeth. So listening to her, it's actually heartwarming when you listen. Someone from a global organization describing how one may tackle surgical issues in Africa, exactly the way I would approach it. So that's really very significant from my side. And I think this is that continuity and that momentum that we are all discussing today. It's good to bring in this conversation and follow-up moment. Yes, as you put it right, this is an accountability moment. And this shows that the conference that we are talking about was not a conference like others. And believe me, I attended some, but I have really had this kind of follow-up feedback kind of meeting a year later to see back and see if we didn't lose time and money to organize that conference. And I hope that people are following us, and those who supported the conference will feel like me that that is not a loss of money and time. If I go back into this conference, I will not go into detail what happened, but I was feeling it was the right moment and the right vibe, as one may say, in the rooms and after it. If you meet people, everyone is remembering that moment. So we had a number of recommendations at the end of the conference. They were like 6, but I will summarize them into 2 big points to make my point clear. So if we read well what we recommended, we can say it was clear, obvious that the participants was willing to improve on South-South collaborations so that people in Africa do much together. So, and in that line, a number of events happened from then to now that I may call it was direct results from the conference. One of the few highlights I'm going to share in that movement of bringing Africa together in terms of surgery. So we created the first Pan-African Surgical Association for Plastic Surgery. The Pan-African Association of Plastic Surgery was just like a direct consequence of that big conference. And now we are finishing the processes of registering it, which is going to be an umbrella that very specialty is going to be working under in Africa. But however, there is also another direct kind of result from that conference. So I knew a few African surgeons, but after that conference, we became as a big village. And we realized that we have a lot to share that people may think. Now I have my resident going to Togo under Professor Sena. I have residents from Tanzania coming to me. I send my resident in Ethiopia. So we find that, oh, look, you do this and I do that. Why don't we share this? And now we are building a big kind of programs that we sharing the resources we have. And I always say that we are not poor as people may think. We have a lot to help us go forward. If I I see the collaboration who are coming out from different regional blocks. Probably my colleague Stella will talk around that better.
Mhm.
So if you see how COSECSA is now collaborating with the works and other sister colleges, so it's also that kind of momentum that Africa is trying to share, send residents here and there, train together, get our colleagues as visiting professorships, professors. I went to Tanzania to teach there because I was invited by a colleague who just was part of the conference. So I have colleagues coming as external examiners for our programs. So we are now trying to share and see that we are not as we are a few years, but we are have that kind of a lot to share that we are going to build on. So on the second point of that,
Oh, go ahead. Go ahead. I do want to bring Stella
yes,
into
I
this
want,
because, but go ahead.
I want to just say that that was one of the big recommendations. But further to that, if you summarize the other recommendation, you find that we also give this message that we have to shift the narrative and the conversations at national, regional, continental level around surgery. And that's where now you see initiatives coming on. You had something called the PASHEF. PASHEF is the Pan-African Surgical Health Care Forum, which is now a big ministerial level kind of initiative that is Ethiopia a few months ago, and now even took this a little bit further, engaging African Union, and now PASHEF is under Africa CDC. So it's now taking that level of conversation. And those who follow African agenda, you had that last week. SADC adopted a SADC surgical healthcare strategy. And this kind of big moments and the momentum around the continent is actually coming out of all that. So that's what I would say in terms of what I see that was directly fruits from this big important conference. I still have few points to add on that.
But
Yes.
first, Dr. Faustin, can I bring Stella in for a moment and I'll return to
Yes,
you?
please, yes.
Because there are a few things you mentioned that I'd love to hear Stella's reaction to. So we were just hearing from Dr. Faustin about the momentum, that there has been momentum and also several coalitions that have come together. He mentioned the first Pan-African Surgical Association for Plastic Surgery, the Pan-African Surgical Healthcare Forum. And then I loved the line, you knew a few African surgeons, but now it's like a big village. And so that brings me to you, Stella, because I know that COSECSA really sits at the intersection of education, accreditation, and regional collaboration. Um, Training is just one component of all of this. And what I want to hear from you is sort of the training and like what are these other steps that are needed? So, from your perspective, what are the biggest barriers that stand in the way of scaling the surgical workforce? Training just being one element. Can you expand on what more is needed? And I'm guessing it has a lot to do with some of the kind of coalition building we just heard about from Dr. Faustin.
Thank you, Catherine, and thank you everyone for having me here. And I'm so delighted to be part of this very important session. I want to appreciate Operation Smile for their Operation 100. I think it begins with a deep-rooted problem that we are having in the community. So going to your question, COSECSA trains within hospitals, and currently we operate in 153 training sites in 24 countries. We have 954 trainers across the region. We know the health workforce is the backbone of a very strong health system. COSECSA has partnered with Operation Smile to tackle challenges that are being faced in the region and is contributing to health system strengthening. However, there are persistent challenges like limited training capacity. Just like I've mentioned, we train within hospitals, so there are very few training sites compared to the need. Of course, there are very many trainees that each time we have an enrollment, we have many applicants, like 650, but are able to take half of that. Some lack training sites, some lack funding. Another challenge that we have is an equal distribution of health workers or trainers in the region. You'll find that quite a number is in the central region. COSECSA, in partnership with Operation Smile, has started going to the rural centers, rural training places, whereby we can accredit a training site that has the sufficient infrastructure to take on quite a number of trainees. However, there are challenges of infrastructure, fragmentation of regulatory systems, whereby you find in some countries, they may not take up the fellowship training program. Others would tell you fall under the Medical Council. Others will tell you it's the National Council for Higher Education. Others will say you're under the Health Ministry of Health. So these are the challenges that we are having. But that notwithstanding, COSECSA partnered with Operation Smile, and we've tackled quite a number of them. One, harmonizing accreditation standards, whereby the standards we are looking at look at the clinical capacity, human resource, infrastructure, administrative, and also accessibility. So in 2022, with support from Operation Smile, we were able to assess over 86 training sites. And out of those, we identified new plastic surgery training sites, and where some of our trainees have actually transitioned from trainees to trainers and program directors. So we have tackled that in that way. Another way that we've tackled the challenges is standardization of the curriculum. We call it a one regional stamp, whereby one curriculum works across the region. It will be a COSECSA fellowship in Uganda, in Rwanda, in Burundi, Kenya, everywhere. And that harmonization and standardization of the accreditation of qualification has helped streamline all the challenges, most of the challenges that we are having, especially in terms of the shortages. We've, of course, not reached the targeted point, but I can tell you we are on track. Third is faculty development. It's just like I said, trainers are very few, and it's not that they are few in some instances whereby people are willing to train, but if you find a training site in the rural area, a young trainer will look at what facilities are in that place. It comes back to schools, electricity, clean water, hygiene, for one to take that decision and say, I'm going to work in a rural district or something like that. And that's why I think Operation Smile is a solution to that challenge, because now they are beginning from the root to train the surgical team. By the surgical team, I mean a surgeon, a nurse, anesthesiologist, obs-gyn, and all those are able to conduct procedures, surgical procedures, especially essential ones. I think I can end there. We'll add on later. Thank you.
Thank you, Stella. I do have one quick follow-up question for you, which is in terms of access and equity in our conversation, it's not just about access to surgery, but it's also about who's performing the surgeries. And I know that women are underrepresented in surgical training and leadership across the continent. And I wonder if you can talk about what are the structural changes to ensure that are needed to ensure that women can enter, and not just enter, but remain and advance in this workforce.
Wow, this is amazing. Thank you for that brilliant question. We understand that workforce sustainability is fundamentally linked to who is involved. And in EXA, in the EXA region, especially for COSECSA, where the women have significantly remained low in terms of training, in terms of also being training as well as work in terms of the distribution in the region. And that gap of women undermines the equity of surgical care in the region. Although COSECSA has really expanded the number of women to 24%, at least we now have 215 women surgeons out of 1,148 graduate women surgeons. At least we have 215. And in terms of training, we cover 18% of the total number of trainees. But that also mentioned, we have structural barriers. And these barriers, some of them are inherited. They are historical barriers in that from way back, I think some of us were not yet born, the medical field was not for a woman, it was for a man. So we are inheriting that problem. And however, people still think that they have expectations of a woman in terms of responsibilities, in terms of caregiving, in terms of accountability, and that has kept a woman low. But that notwithstanding, there are also work policies that do not accommodate women. There are gender responsive issues that also affect women into joining the training program, but also finance is also part of it. Now, COSECSA, in partnership with Operation Smile, we've been supporting women to tackle that problem. One, we know it begins from the grassroots. Now, how do we help these women? To fund them, support them to join the training, the surgical training program, which Operation Smile has done in the past 5 years, picking medical doctors from year 1 of specialist training to year 5. And in fact, this year we'll be graduating Operation Smile cohort, the very first cohort of 15 trainees. Secondly, I think COSECSA has also developed gender responsive policies, and these tackle paternity and maternity handling, especially in their places of work, whereby a woman surgeon is given 14 weeks of maternity leave. We've also structured their training program in a way that each time you come back to your training, you are given more cases of procedures so that you're not left out in terms of assessment where the time comes and you're supposed to sit your examinations. So these are the structural barriers, but also we've talked of mentorship. Operation Smile has supported quite a number of women to partake leadership courses, global surgery courses at Washington and also University of Cape Town in South Africa. Operation Smile, together with COSECSA, is also supporting another arm of women. COSECSA established Women in Surgery in 2015. This is strategically to mentor, to train, to groom women, to partake leadership roles, to also mentor others, but also remain within surgery, not just training, but lead within surgery. So Operation Smile supports women surgeons to do research through COSECSA, to take up leadership roles in different institutions in the US. Also, women in medicine, I think, is another big platform where women have been encouraged to take up leadership roles, to take up surgical training roles. But in terms of Women in Surgery Africa, a very huge arm for COSECSA, we have national chapters, and these have representatives at country level. And each time they meet quarterly, they have their high teas, they have dinners, they have mentorship programs. In fact, the Dr. Faustins were envying them and saying they're also going to establish Men in Surgery Africa, because the women have Women in Surgery Africa. So yeah, so these women come together, mentor each other, train, and also go to medical schools to encourage the medical students, especially women, to join the career path of surgery.
Absolutely.
Besides that, as a college, we've revised our governance structure, whereby at least 30% of the women representative on council level is taken on board. Thank you.
That's great to hear. And I do want to quickly hear from Dr. Coté on this because Stella, you mentioned all the ways you've partnered with Operation Smile on this effort. So Dr. Coté, why is that such an important pillar of the strategy and how do you feel it's going?
Well, you asked what success looks like, and it was for a reason that I brought up Port Reitz Hospital, which is on the coast of Kenya. That's because the entire surgical team there, surgery, anesthesiologists, the nurses, the biomed tech, are women. That's a very rare sight to see, even in the US.
Oh,
but
yeah.
If we're going to address capacity, that means we need to tap net new resources of talent that haven't been traditionally part of the pipeline. If you think about who traditional family caregivers are, it's women. Women do most of the unpaid and the paid care in the healthcare system, but they only have 20% of the leadership positions. That means we have to take specific action and policy-oriented interventions to change that game. So this is not just, this actually shifts our discussion from one that's not just about capacity, but one about scale and speed. And I love that. Thinking about how we can work on upskilling, on expanding the places from which we bring people into the healthcare system as providers, and how we help lower barriers that don't necessarily need to be there. With women in medicine, women in medicine tend to stay where they're trained. There's not the same problem with brain drain. Although once people are trained, they're welcome to go anywhere because they're going to go on. And as our colleagues at research documented, they're going to keep training other people. So there's going to be exponential growth to the results of these interventions. But women tend to stay where they are because they have families, because they have a commitment to their communities. And that creates educators and more mentors. There's also powerful male leaders like Prof. Faustin, who does champion Women in Surgery Africa and Women in Medicine at Operation Smile, where, as Stella talked about, we convene countrywide and regional-wide fellowships for women in surgery so that they have each other, to overcome the unique obstacles that women tend to face in these traditional settings. We also need to think about non-traditional ways of training for capacity, because the traditional ones, while we need to augment them, are too slow to meet the need for surgical care for everyone. By the time 2030, we've set ourselves the next accountability moment with the Sustainable Development Goals.
Absolutely. I want to pick up on something that you said and hear from Dr. Faustin on this. So you mentioned women in medicine tend to stay where they're trained. And of course, as we've sort of touched on before, when it comes to this shortage of 2.2 million surgeons, the challenge is not only training, but retention and distribution. And Dr. Faustin, earlier you were starting to outline recommendations in terms of shifting policy on surgery. What I would love to hear from you on is lessons from Rwanda specifically, because I mentioned earlier, your leadership at a national level and also on a regional, continental level. How is Rwanda dealing with that challenge in terms of not just training more surgeons, but influencing whether they continue to practice and whether they stay? How is Rwanda aligning surgical education, workforce planning, and national policy to ensure that newly trained surgeons are retained and deployed in the districts where they're needed most?
Very good to come after Stella and Elizabeth and just talk about Rwanda. When Stella has put nicely the regional perspective around the matter. And it is the same back in Rwanda. And when you see the numbers, people talking about in absolute numbers, people may think we are almost there. If we talk about 1,000 trainees, 1,000 surgeons, it is not yet there. So we need 10,000, 10 times more. And if we are in Rwanda, then here Rwanda is a small country, 14 million people, with 172 surgeons as I'm speaking now, but we want 1,000 and more. And we did train. And to put well into the perspective, the question you're asking, what are the lessons and how are we doing it in Rwanda? So Rwanda has a number of points to share, not to call it lessons, because we are not teaching anyone here. But we are actually sharing the experience of what we trying to bridge the gaps here in Rwanda. So we, as a national strategy that we call 4x4 strategy, it means we want at least to multiply by 4 the number of health providers that we are having in the next 4 years. So health providers are including surgeons. I remember I was joking with one of my HODs in the ministry, telling him, no, in surgery, multiplying by 4 will not be enough. You have to multiply it by 10 so that at least we have the minimum. So that is a national strategy. And this is create a framework under which everything is going to be done. So now down to there, we go to the training institutions and hospital levels, and we organize in a kind of hub and spoke model where we have a big center because we cannot afford to have surgeons everywhere now. But we have a big hospital with surgeons with a catchment area, as we call it, under which we have 1, 2, 3, 4, 5 hospitals, which are going to be supported from the central level in both patient care, training, and mentorship. And further to that, infrastructure-wise, we think that we cannot just train. We have to train, motivate, retain, and much better, create a very good environment where surgery can be done and where those teams around the surgery are going to feel supported and comfortable when they are doing what they do. And then that's how now the government and the partners, we are investing into infrastructure, increasing the number of theaters, creating ICUs, increasing perioperative infrastructure, etc., so that things can be done and in a much more comprehensive way. But most importantly, I want to come back to what Stella was saying, shifting training from central levels to local levels or district levels. That is having multiple benefits, by the way. Because you train people in the exact conditions in which they are going to be practicing in, and you also give them opportunity to serve the population that they are going to be with for their entire career. So it's a kind of limit what we call internal brain drain, which is actually shifting every capacity from rural area to the cities. But when you train there, you get comfortable, you know the area, you get used, and when you are deployed there, it is not strange for you. You understand the people and you want to contribute. And actually, that is maybe one of the biggest strategies that I would call every country to try and implement. Over to you.
I'd love to hear either of you jump in on this because, of course, when I hear Dr. Faustin talk about this need to shift to training people where they're based, that makes sense. But my initial reaction is, how do you do that? That's difficult to implement. That's training across multiple places. We've had some questions come in from our audience ahead of this event, and one of those questions had to do with the role of technology, which I think can be a game changer in answering that question of how do you implement that. But any reactions to that, if that's the way forward, meeting people where they are and in the places where you want them to stay, how do we do that and what role can technology play?
Can I come in?
Absolutely.
Thank you. So I think you are totally right. Technology is going to be a game changer, and actually I call it an equalizer. It is the only thing, if we take it right, we can help us to move quicker and faster and catch up the gaps. So however, we are surgeons and we train surgeons. It's very rare that you only learn surgery online. You have to have a hands in, and you have someone taking your hand and helping you to drive, as you know, the driving license of those who are connected. So it is very, very difficult to see someone driving and one day you start driving. You really need to sit there on the learner's seat and you shift one day to the driving side and the other guy is still there to help you drive.
That's a good analogy. Can't learn to drive a vehicle without sitting in the vehicle.
No, you can't. So, and that's, I think technology is going to help telesurgery, telementorship, following up from remote, moving people outside theater. That's all good strategies for initiation. But at the end of the day, you need a surgeon who has hands-on skills. And that is now is going to be tricky. And that is tricky part of the things. Traditionally, patients used to move to healthcare providers. People transfer to surgeons. people moving from rural to cities, because this is where surgeons are. I think the reverse movement is also possible. Instead of me waiting for a patient to come to me, I have a year-long schedule in which I'm going to go in different corner of the country and meet patient there. Because in surgery, we have two kinds of surgeries. We have what we call emergency surgeries, and you have also elective surgeries, which can wait a little bit. So emergency surgeries are transferred in the normal processes, but elective surgery can be scheduled and grouped, and 1 week, 2 weeks, massive hands-on training happening at the same time that you are also training hundreds of people. That is this kind of shift and a little bit of thinking out of the box that people have to come in and bring in some innovations about how we can reach to the maximum people for both purposes. I mean, training purposes and patient care purposes. So now maybe Stella and Elizabeth have something to add on that.
Yeah,
but
please.
that is what I was saying that really can catch up things.
I'm sure, as Faustin and Stella have illustrated, if we want to make access to safe surgery available to people within 2 hours, that means there needs to be a well-trained, complete surgical care team in a critical hospital within 2 hours of where they live. Those are district hospitals that are not traditionally academic hubs and resources. So we have a specific strategy to that. We identify the critical access hospital. Then we identify, it comes down again to the people. Who is the surgeon? Who is the anesthesiologist? Who are the nurses? Who are the biomed? Who's the nutritionist, the psychologist that need to be trained? Now technology comes in because we've partnered with Surge Hub, with ESICON, with the WFSA, World Federation for the Society of Anesthesiologists, to have critical didactics that are gold standard, global expert-driven didactics available by virtual platforms. That doesn't get there, though. As Prof. Faustin said, it's repetition, repetition, repetition. You have to have muscle memory. Even simulation doesn't bring you all the way there. So what we do now that we know the names of the teams, we bring them to our intensive surgical programs or camps, whether that's in a hub or where there's a high volume of cleft surgery or other care being delivered, so that they can have one-to-one mentoring side by side, a training surgeon from a district hospital with an expert surgeon. They might be from a high income, a local or a regional hub, and then they go back. They do that until they meet a competency-based evaluation. And now not only are they competent, but they feel confident that they can deliver care where they live to a standard that is one that is globally accepted. The golden ticket here, though, of what does technology enable, that those teams aren't alone anymore. They have each other around the OR table and in the perioperative spaces, but they also have the other people they trained with at the regional trainings that re-emphasize the online trainings, with their mentors that they can access through telementorship. We have nurses that went to regional trainings. They're on WhatsApp groups, and when they run into a roadblock, that's one that's administrative, they text each other. How am I going to get around this in order to deliver the care that I was taught to deliver? And no one is a better expert than those that are right on the ground, on the front lines and closest to the problems. And no one can help them better than other people in those same situations. That means they're not alone. They are connected. And again, it goes back to what Prof. Faustin said. They realize we're part of a village, and it's a global village, and it includes all of us.
I love that point, and this has definitely been a recurring theme in our conversation, is the importance of community, and hearing from you that perhaps is one of the greatest roles technology can play here is in facilitating that community. Stella, did you have anything to add to that?
Yeah, actually, close to that, I think we need to look at, without looking at training or bringing teams, we need to look at numbers. And that's what COSECSA works on. One, we do not have to move people from where they are, but we can provide platforms, digital platforms for training. COSECSA has a learning management system, which is cool for surgeons, digital libraries. It also offers online webinars. It also offers case studies online for even a rural person in the village to access the training same time or real time with a person in the urban center. We now have regular faculty webinars and training sessions. So I think embracing digital platforms and accessing digital libraries, but also telesurgery, and especially for the non-surgeons who are essential workers in terms of supervision. If they are maybe helping surgeons, they need to be helped, they need to be supervised, but we also need to look at quality assurance. We need to look at regulatory and compliance of what kind of surgery is conducted by anyone who is trained in the rural area. So looking at numbers, it all comes down to training as many as we can, distributing as many training sites in the region and up to the community level. Thank you.
Great. We have so many questions to get to from our audience, so I'm going to jump around here a little bit. But I did want to ask one more question on technology specifically, because there is a question on AI, which of course is a topic on everyone's minds, and we haven't directly touched it. There's a question on what is the most viable roadmap for integrating AI into perioperative anesthesia care across diverse African healthcare settings? So we have talked about the limits of technology in this context, but I do want to make sure we don't gloss over what could be some big potential gains here with AI. So any comments on that?
Maybe if I come in, as COSECSA, we are trying to bring in AI in our training program, and it will be study stash, but that will be for formative assessments, not necessarily a separate platform of AI, but AI embedded within the existing resource materials that are online, whereby a trainee will be able to assess themselves, post their work, they will be assessed by the program director or the trainer. They are reviewed and assessed at the end of the year to see if they are capable of conducting certain surgeries. So yeah, AI is on everyone's mind, and equally COSECSA is taking that route. We're just starting, but we think for one to start structurally, you have to begin within the training program, within the resource materials, without necessarily going to robotics or minimal invasive, which can be done in a different training site. Thank you.
Thank you. If I may come after Stella about that, and I would say AI is not going to replace surgeons, but what is sure, surgeons using AI will replace those not using it. So we cannot afford not being on that journey and go take this momentum. So we have a lot of applications around AI, from diagnostics to follow-ups to different models that we can use in surgery. I just wanted to make one simple point about the data people use to train AI models. So that's where we really have to pay attention. We should be in this move so that this machine learning and all mega data that people using to train their AI models and platforms, we have to have our data represented so that the AI models that people are going to be using are not from somewhere else, not customized to the patient we have, not customized to the processes we use, so that we generate good answers from any AI engine that we may use. So that's the only thing I want to add on what Stella was talking about.
If I may add, sorry, Catherine, just one small thing. We also use AI. It's a program, it's a platform called Entrust for examination. And these are clinical examinations. So it's a platform whereby a trainee or a candidate will go to that system. It will show him the patient. He has to examine the patient, know the diagnosis, when the patient will be, what kind of review is required, what kind of medication. So yeah, I think just like Dr. Faustin has said, AI may not replace a surgeon, but AI will accelerate the quality care in terms of patient outcomes through processes, but not the final product. Thank you.
I want to bring in another question from our audience that I greatly appreciate, and it's around sustainability. So of course, we've heard about these partnerships, and Operation Smile has been central to these partnerships. The question is, how can resource-limited countries integrate safe surgery into their national health plans without relying excessively on NGOs? And Dr. Coté, I'd actually love to start with you because I'm sure part of the goal here is to be catalytic and, that these programs won't always rely on Operation Smile. So I think that probably points to the question and how does that look moving forward?
This is absolutely the model that Operation Smile is adopting, and it's one that's very strong, regardless of if you're AI enhanced provider or not. Healing happens between people. AI enhanced people, perhaps it happens like more finely and acutely. We do use very advanced AI models, even in planning cleft surgeries. But back to your question about sustainability, we don't want to create another situation that is one like PEPFAR, where everything is provided, and if it gets shut off by the collapse of governmental aid from a high-income country, the help stops. That is not it at all. These are seeds that we're planting. In education, you train one cleft surgeon, they go on to train 15 to 20 other cleft surgeons who in their caseload then in their lifetime reach over 1,000 more surgeons. So we're talking about pennies on the dollar for training. What I love to say about education is wars, natural disasters, political instability doesn't stop it. You see people training people in war zones. I have personally been there. You see them training them across boundaries in stateless nations. You see them training each other in the midst of typhoons. You see them training each other no matter what can happen when electricity collapses, if AI goes offline. And so this is sustainable. Not only is it sustainable from looking at supply chains or looking at geopolitical instability, it's sustainable in that it is growing exponentially. And so that's what we can rely on. One person trains more people. And the more you knit that network together, the more quickly you'll scale with speed that network. So that's what we're going at right now, scale and speed, as well as capacity building.
I love that, scale and speed and exponential growth. We just have a couple more minutes here. So I suppose my question for all of you is, we talked about how there's been a year since this conference. This is an accountability moment. So let's look at the next year. And if you have one thing you want to see happen in the next year that you want to leave this audience with, what would it be?
May I come in first, please? Because
Sure.
I want to little bit, 1 minute to follow up on the sustainability issues. And that's actually what is going to lead us next year, because if there is no sustainability next year, will not happen. So we think that sustainability starts from within. So it means from local ownership of all this. So this is not, and the conversation we are having here as a Pan-African follow-up on Pan-African conference, it is not an American issue or Operation Smile issue. This is an African issue which should be owned by Africans, and from our top leadership to understand that surgery is an integral part of universal health coverage. And whatever happens should be integrated and aligned with the local needs and the local context. So it should be owned from within. And this is the only way things are going to be sustainable. We may train hundreds of providers. If no one employs them, that will not happen. We may build hospitals, but if no one maintains them, that is going to happen. So we really need to think beyond a small cycle of people, surgeons, NGOs, bring political and politicians on board, make sure that our governments, our institutions own this and make this their own agenda. That is the only way sustainability is going to happen. And then we are going to talk about tomorrow and after tomorrow and the year after.
Stella, we'll go to you and then close with Dr. Coté.
Yeah, thank you. Okay. Yeah, going to sustainability, I think we need to prioritize structured skills transfer and mentorship alongside service delivery. We also need to work with institutions, health workforce plans, which Operation Smile is doing, and also standardize training and care. But then, in a nutshell, what I would go with my last statement here, we need to train as many surgeons as we can, accredit them, examine them, graduate them, retain them. In that way, we shall expand the health workforce, will avoid dependency in the long run, yet building sustainable health systems across the region. Thank you.
Dr. Coté?
And finally, to echo my colleagues, I'd say we would love to see more independent, complete operative teams, including the pediatric anesthesiologists and anesthesiologists that make surgery so much safer and will uplift the safety of surgery for all of the surgeries that happen by all the newly trained surgeons. So more independent, complete surgical teams in those critical access district hospitals that is co-owned, planned, really driven by ministries of health that are pinpointed as those that are of priority to the people whom they serve, that are maintained by local resources or at least co-invested in by local government resources as well as independent or the civil society, and catalyzed by international partners. So in brief, locally led surgical teams that are globally supported.
Well, with that, I want to thank all of our speakers so much for this conversation and for the work that you're doing to make safe surgical care more accessible and more equitable. Thank you to Operation Smile for your partnership with Devex for today's event and your leadership on this issue. And thank you to everyone who joined us. We look forward to continuing this conversation and watching this progress continue. Thank you.
Thank you, Catherine. Thank you, Elizabeth. Thank you, everyone.
Thank you. Thanks, Prof. Faustin, Stella, and Catherine.
Thank you all.